Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today, as usual, some more important rules that hopefully will help you take care of your patients. Rule number 176. Take a history like a pediatrician. So if you've listened to the podcast before, you know I'm a very big supporter of getting a good story, getting a good HPI, and just obtaining good history. Of course, I have nothing against physical exam, but many times in pediatrics, physical exam doesn't really help. It's all about getting a good story. Sometimes, as emergency providers, we actually have to get even a better history, and I call it get a history or take a history like a general pediatrician. This is something that I find many emergency providers are not necessarily familiar with, they're not necessarily comfortable with, but sometimes it's a necessary step in the care of the patient. A good example is the baby, the newborn that comes in with chief complaint of fussiness. When I see a patient with fussiness, I often perform a physical exam and take a history like a pediatrician. Talk about the formula, the feeding schedule, how much, how often does the baby stool, etc. All those things that as emergency providers we don't necessarily care about on a regular basis. However, in some circumstances, it's important to take a history like a pediatrician. A very good example for this situation is the child that comes with failure to thrive. Under those circumstances, one must get excellent history with regards to feeding schedule, the amount, the kind of formula, breastfeeding versus formula, calculate the weight gain in grams, make sure the patient is taking or gaining at least 20 grams per day, etc. Take a history like a pediatrician with a lot of what seems to be minor details that have really nothing to do with emergency medicine, yet are necessary for the care of the patient. This might be easier for you if you trained in general pediatrics like I did. However, if you're an emergency provider who trained in emergency medicine, it's always easy to look up normal feeding schedule for a newborn, be familiar a little bit with the different kind of formula, the caloric intake of formula, etc. Another good example for this situation is the patient that comes in with anxiety or depression. Under those circumstances, I find myself sitting down with the patient sometimes for a very long time and talk about school, stressors, family, the boyfriend, the girlfriend, etc. Again, those are things that are not necessarily very intuitive as an emergency provider, but when the child comes in with symptoms of anxiety or depression, I think it's incredibly important to do a good heads assessment and talk about a lot of things that may seem minor to you or don't represent emergency medicine at all. However, under those circumstances, it's best to obey rule number 176 and take a history like a pediatrician. Ask about what seems to be minor, maybe even irrelevant details that are relevant in the field of general pediatrics, but not so much in the field of emergency medicine. Rule number 177. Let the parents know what to expect. This is a rule I try to obey in order to hopefully prevent those bounce backs or those unnecessary visits to the ER. A good example is when I see a child who maybe fractured his hand or his limb and has some bruising. Parents often come to the ER because the bruise has been changing in color, etc. So this is something I feel very strongly you can tell the parents before they leave, so hopefully you prevent this ER visit. So mom and dad, just so you know, that bruise is normal, it's supposed to be there, your child had a blunt trauma to the extremity, and I want you to know that very likely this bruise will change color with time. This has to do with the amount of red blood cells that are sort of decomposing in the area, which is normal. So right now it looks a little blue, it may turn green and then yellow, those are all normal. Another good example is the child that comes in with red eye secondary to conjunctivitis. So those of us who've been practicing medicine for a while kind of know that almost anything that has to do with the eye looks terrible in the morning. And viral conjunctivitis is a great example. Parents often bring that up as part of the HPI. When the child wakes up, his eyes are matted and there's a lot of discharge and it looks very swollen. And that actually makes a lot of sense. When you are sleeping, you're not blinking all night, so when you wake up, there's a lot of discharge in the eye. The swelling around the eye is all edema, meaning fluid, and where does fluid go with gravity? When you're laying down, so it's all going to be accumulating and look very swollen in the morning. That is something that I tell the parents when they present with viral conjunctivitis, just so they don't get very worried the next morning. So mom and dad, just so you know, likely Johnny's eye, which has viral conjunctivitis, which is a mild infection in the eye, will very likely look worse tomorrow morning. The fluid that we all see causes the swelling, and in the morning the fluid goes with gravity, so it might be very swollen. The discharge you saw this morning, likely you're going to see the same again tomorrow because we don't blink all night and the discharge accumulates. So I think it's very important to tell the parents that despite the antibiotic drops you may be prescribing, which may not help because it's a viral illness, likely the eye will look worse tomorrow. Another good example is when I provide dexamethasone and or racemic epi for croup. I think it's very important to make sure the parents understand neither one of those medications does anything for the virus. So mom and dad, just so you know, your daughter will still have runny nose, congestion, and even fever for the next few days. All of those are normal, but she should not have any difficulty breathing, and she definitely should not have that stridorous sound that I indicated when she came in and you noticed yourself. But I think it's very important not to send the parents home with the notion that the steroids and the racemic epi you gave in the ER today will fix the problem. Unfortunately, they do not. Rule number 178. Max out before you call the consultants. So this is a very good rule to follow, especially when you're an attending working with the same consultants for maybe several years. You want to be the attending who does everything you can on your own before you call them and possibly wake them up at 2 a.m. and whatnot. Again, always good to explain with an example. So a few weeks ago in the pediatric emergency department, I saw a kid with one of my fellows that came in with what looked like a very bad corneal operation. He had some mild trauma to the eye, but now had a lot of pain. And both my fellow and I noticed that in the middle of the eye, right next to the pupil, there was what looked like a foreign body. So of course, we stained the eye with fluorescein, did not see corneal abrasion. I was actually expecting that maybe the sidal test will be positive because the kid had really significant pain. However, thank God it was negative. I also did a slit lamp exam, nothing fancy, just using the ophthalmoscope. I everted the eyelid, did not find any foreign body, and really could not find anything that explains the patient eye, with the exception of this very odd looking foreign body-like material that we were not able to remove. Since the kid was still in a significant amount of pain and we really had no idea what's going on, did not want to send the kid as is, we called our ophthalmologist, and after sending him the pictures, he indicated that what we saw was actually signs of early infection, and that was actually an infiltrate, white blood cells, in the middle of the eye. Honestly, I've never heard of that, did not know that exists. He recommended Vigamox several times a day, as well as ophthalmologic ketorolac for NSAIDs for the pain, and follow up with him in a few days. Several days later, I saw the ophthalmologist in the physician lounge who actually indicated to me how happy he was that I tried everything I could before calling him. I did the fluorescein stain, I everted the eyelid, etc., etc. I think consultants often appreciate that you as an emergency provider do whatever you can for the patient and trying to figure out what the patient has before you just call them and say, hey, what do you want me to do? So remember, max out before calling your consultants. And that is it for today, guys. Thank you very much for listening. Let's review briefly what we learned. Rule number 176. Take a history like a pediatrician. Remember, sometimes things that may seem like general pediatrics and are far from emergency medicine may be necessary for you to figure out what the patient has in order to get a good HPI. Rule number 177. Let the parents know what to expect. Setting up the expectations with parents is something that can help you prevent those bounce backs or those unnecessary visits. It's also something that often alleviates their worries. Rule number 178. Max out before calling your consultants. Do whatever you can to find the problem, treat the patient, and after you feel like there's nothing else you can do and you're still in a bind, call the consultant and present the patient. Obviously, make an assessment and make a plan. I think consultants often appreciate it that we do whatever we can before calling them as opposed to just calling them when the patient comes to the ER. And that is it for today, guys. Thank you very much for listening. I hope you enjoy PEM Rules and my articles on EP Monthly. Please subscribe to the newsletter and be in touch with whatever it is you want to hear about, or if you want to come on the show as a guest, please let me know. The following outro is another song by my outsourcing pianist who has been doing an amazing job. This is a song by Ariel Speedwagon and it's called I Can't Fight This Feeling Any Longer. Great job on the piano. Thank you very much. I hope you like it.